Stage 3 colon cancer in 26, well, yeah, that's still a challenge. And the biggest challenge is really to see whether we still have this stage 3 definition being still valid. Because we do have learned that if we look to different prognostic factors, including ctDNA and the ctDNA defined minimal residual disease, so the question whether we can detect circulating tumor DNA, yes or no, is a way stronger prognostic factor than TNM staging. Or in other words, we may question whether there's really a difference between stage 2 and stage 3 when we also have ctDNA as a very strong prognostic factor. So therefore, having said this, maybe the considerations today is not stage 2, stage 3, maybe the consideration is what can we do in patients with a high chance to relapse versus a patient with a low chance to relapse or to have metastatic spread later on. My take is that we shouldn't be too strict here, and we should be more flexible also when it comes to chemotherapy intensity when we think about adjuvant treatment. And adjuvant treatment generally consists of any fluoropyrimidine, 5-fluor, or capecitabine in patients with oxaliplatin, and oxaliplatin also 3 months versus 6 months as the question of the IDEA analysis, which came out now nearly 10 years ago for the very first time. And maybe it's not, let's say, a strict 3 versus 6 months oxaliplatin, and maybe it's not, do we need oxaliplatin at all? Maybe it has to do, let's say, with the prognostic situation, and the poorer the prognosis is, the more intensive chemotherapy should be, and more intensive means combination chemotherapy should be preferred over single agent, and 6 months of oxaliplatin should be preferred over 3 months. By contrast, if we are in a low-risk situation, it may be enough to administer 5-fluor or capecitabine at all. So therefore, it's a more continuous prognostic variable than really strict rules. And let's say we have learned 2 more things in 26, which we have to consider, although they may be not yet super clear standards of care. The first is neoadjuvant treatment. Difficult to predict which patients should be treated with neoadjuvant treatment instead of being treated with adjuvant treatment after resection. But the Foxtrot trial and the data which came out also in these post hoc analyses from Foxtrot tell us that patients with a bulky disease and a clearly T4N plus disease should be better treated with preoperative chemotherapy than with operation first and adjuvant treatment later. And the second thing is, again, MSI high situation and the question, what should we do with the checkpoint inhibitors there? They can be also given either as neoadjuvant treatment and, as just mentioned in the Atomic trial, with adjuvant treatment. So therefore, the general scope is prognosis is more dependent from many factors than just TNM staging and stage 2, stage 3. Maybe ctDNA gives us a better prognostic information. One should be flexible and also account patient condition into the decision making. And next to this, neoadjuvant treatment in patients with bulky disease, as well as the specific treatment of MSI high patients with immune checkpoint inhibitors. These factors have to be considered to make the best decision.